Good morning. So my name is Lindsay McLaren. I'm an associate professor here in the Department of Community Health Sciences and the O'Brien Institute for Public Health. My research is focused in the area of population health and health equity. And currently I have a program of research that investigates these issues through the lens of community water fluoridation and dental public health. I have the honor of introducing our keynote speaker for today, Dr. Arjumand Siddiqi of the Dalla Lana School of Public Health at the University of Toronto. Dr. Siddiqi is someone whose work in population health and health equity I really admire, and whose work I think makes a very unique and important contribution to the field. So I'm personally very excited that we've had the opportunity to invite her here for our spring forum. Dr. Siddiqi received her doctorate in social epidemiology from Harvard University, and she's currently assistant professor at the Dalla Lana School of Public Health at the University of Toronto. She also holds a Canada Research Chair in Population Health Equity. She holds additional appointments in the Department of Pediatrics in the Faculty of Medicine at the University of Toronto, at the Hospital for Sick Children in Toronto, and the Gilling School of Global Public Health at the University of North Carolina, Chapel Hill. Dr. Siddiqi's research examines the role of policies, institutions, and other aspects of societies in shaping inequalities of health and human development across the lifespan. She focuses primarily on inequalities along axes of socioeconomic status, race, and immigration within and between OECD nations, the contributions of income inequality and social policies to these inequalities, and the methods and metrics that enable scientific inquiry in this area. Dr. Siddiqi is an alumnus of the Canadian Institute for Advanced Research Global Academy and former associate member of its program on successful societies. So I can't resist but acknowledging at this point that the Canadian Institute for Advanced Research is where this very important book, Why Are Some People Healthy and Others Not, came from. And many people regard this book as the beginning of population health in Canada. It was published in 1994. And especially for those of you who are currently in my Foundations of Population and Public Health class who just read a chapter out of this book earlier this week. We've got someone here. Dr. Siddiqi was also a member of the World Health Organization's Commission on the Social Determinants of Health Knowledge Hub on Early Child Development, and has consulted to several international agencies, including the World Bank and UNICEF. So please join me in welcoming Dr. Siddiqi.
Great. Thank you so much. Speaking of blushing, that was quite an introduction. All of that is actually, for me, more useful in that it brings out a lot of the institutions and the people in those institutions that have been really instrumental for my trajectory. And I can't resist, since a big deal was made out of Canadian Institute for Advanced Research, to tell you that Clyde Kurtzman, who was key in that early stage of population health, was a dear friend and mentor, and departed too soon. I'll cry if I go on, so I'll stop. But really some remarkable people that have been doing this work long before I came along, and that I've really benefited from engaging with. So it's lovely to be here. The other thing I want to do is acknowledge the opportunity to be here, and in particular Leora and Mariko, who have been just wonderful in making this happen. And so I feel like I have new friends. So it's been really nice just sort of in the lead up coming here, and really looking forward to engaging with you all. So I'm going to give a talk, but I'm always happy to be interrupted during, after, whatever is comfortable for you. So hopefully this will start a conversation. So I'm going to talk a little bit about both what I think the research shows in present day about social determinants of health, where it's going, as well as what some real world examples are teaching us. And I'll start with one real world puzzle. And this has to do with children's developmental health in Vancouver that Clyde Kurtzman and his colleagues at the Human Early Learning Partnership had mapped out over the years. So this is Vancouver. It's a map of Vancouver neighborhoods. And Clyde and his team took the EDI. Anyone familiar with the EDI? It's the Early Developmental Index, and it's sort of instrument, and it maps the developmental capacities of 5-year-olds. So in Vancouver, Clyde and his team were funded to map the EDI in every single 5-year-old in British Columbia. And so they went to each school, and teachers filled this out. And so they had a sense of how every 5-year-old sort of developmental capacities were doing. And they created this map that showed the extent to which there were developmental vulnerabilities, meaning the extent to which children were sort of on the lower end of the developmental spectrum versus the higher end across Vancouver neighborhoods. And the neighborhoods shaded in brown are the ones where there was a greater proportion of children who were more developmentally vulnerable compared to the sort of greener shaded neighborhoods where there were less proportion of kids who were developmentally vulnerable. And for anyone who knows Vancouver, you can see that the proportions were higher in neighborhoods that were lower socioeconomic compared to the ones that were higher socioeconomic. So this was 2000, 2001. And as I mentioned, this was every single 5-year-old in these neighborhoods, and that's not inconsequential. So what happened is, as a result of producing this data and showing communities this data, parents, community members, and so on got very engaged, and they said, well, you know, we simply have to do something about this. And so in these neighborhoods where there were higher proportions of vulnerability, there was all of a sudden a sort of outsprouting of various programs, reading programs, library sessions, all sorts of things to sort of boost developmental capacities in 5-year-olds as a result of seeing this data. Well, in 2010, they went back to remap what had happened to children's developmental health. And here is the result. The answer is that things got worse. So after all of that effort, there was actually a decline, a greater proportion of kids in more neighborhoods who were sort of on the vulnerable end of the spectrum in terms of developmental health, and we'll come back to why that might be. Here's the second real-world puzzle that we encountered in Toronto recently. So Toronto, some years ago, about just over a decade ago, had mapped socioeconomic inequalities in adult health outcomes across the city. And this was an endeavor that Toronto Public Health engaged in, and they noticed that health inequalities were large, and so they sort of mounted a decade-long effort to sort of do something about these inequalities. They created programs for low-income individuals. There were everything from breastfeeding programs through to smoking campaigns and smoking education programs and so on. And same thing, they went back to remap health inequalities a decade later to kind of see what the fruits of their labor had yielded, and things were worse. And they said overall health inequalities in Toronto have not improved over time. For the first years of the data analyzed, low-income groups had worse health for 21 of the 34 health status indicators analyzed. So all of these very good, very well-meaning efforts yielding worse results over time in many cases. And for me, the question is, what's going on? Why is this the case? And I'm going to sort of present to you what I think might be part of the answer. And I think it goes back to some of the fundamentals of social determinants of health at first, and we'll sort of progress from there. So if you think about the basic message that the social determinants of health literature has taught us, it's that social conditions, social determinants, are fundamental causes of our health. They are root causes. And this paper by Lincoln Phelan was particularly influential to me, and in that it really nicely spells out why they are root causes. This is the work of Bruce McEwen, a neuroendocrinologist, who does a nice job of explaining biologically and physiologically why they are root causes. And he has this picture of the brain. And he says, look, there is this kind of endocrinological, physiological mechanism that happens in the brain when it perceives threat or perceives stress of some kind. The brain essentially, when it perceives this stress, creates some physiological responses, things like our blood pressure changing and so on. It creates also behavioral responses, anything from sort of this fight or flight response all the way through stress coping mechanisms like diet, smoking, drinking, exercise. Incidentally, some of the major behavioral risk factors we think are associated with the major causes of morbidity and mortality. And what he says is that this mechanism doesn't operate in isolation precisely because it relies on the perception of stress or threat of some kind. And his work and that of others has sort of highlighted the fact that what is happening in large part is that socioeconomic groups are experiencing different levels of threat and stress. And you can see that up here. He says environmental stressors at work, home, in your neighborhood, major life events, experiences of trauma and abuse. These are all factors that trigger these stress mechanisms. They trigger our physiological stress responses. They trigger our behavioral responses. And so what our sort of applied sensibilities have told us is that if that's the case, social conditions are fundamental causes of disease. They come before we behave. They come before our physiological responses. They are the very reason those responses and those behaviors play out. And this is a framework on social determinants of health, and I'm sure many of you have seen this or similar frameworks. And they essentially say the same thing as what Bruce McEwen's brain diagram does, which is that there are all of these kinds of ways that life plays out that are triggered by conditions that cause stress. And what social determinants frameworks have evolved to tell us is that then if it's true that social determinants trigger these behavioral and physiological responses, almost every mechanism leading to health, then we have to do something to change the course of social determinants rather than thinking just about changing each individual mechanism. And so we think that things that operate at the societal level that condition our social determinants and that condition, as Melanie was saying, how social conditions are distributed are probably where we get the biggest bang for our buck in terms of changing health inequalities. So things like social policies, governance, etc. So if we go back to our examples of these puzzles, what went wrong? Well, between 2000 and 2010, we had some really hard economic times. There was a rise in unemployment. There was a rise in insecurity in income and so on. And what the message of this data essentially tells us to at least hypothesize is that all the programs, well-meaning programs on the ground, to funnel into one particular child development mechanism were simply drowned out by all the economic insecurity that families were facing and that affect so many aspects of children's lives. In the Toronto example, a similar story. Toronto Public Health with very well-intended, very well-meaning programs to address particular aspects, particular mechanisms of health, smoking programs, breastfeeding programs, and so on, simply could not drown out the fact that the fundamental causes, the root causes, the unemployment, the higher income inequality, and so on, were operating at the same time that these programs were being unfolded. And the effect of those fundamental root causes just simply could not be overtaken by programs that operate mostly on one or two proximal mechanisms. So that's my story, right? That's my sort of hypothesis about what happened. But I think you should rightfully ask, what is the more direct evidence that this is actually true, that macro policies can actually do something that local programs may not be as successfully able to do? And so again, the question is, what is the actual empirical evidence that operating up here may give us bang for our buck compared to operating down on the proximal level. And I'm going to give you two primary sets of examples. The first is a body of what we call quasi-experimental research that is really sort of taking effect these days. So for a long time, we didn't have very strong methods to test particular policy effects. We weren't quite sure how to make this all happen, partly because the problem with isolating the effect of a policy is that so many other things are happening at the same time. So you don't know what is what. So scientists often look for these moments where some change has taken place in a policy that allows you to more or less isolate the effects of that change. And so there's been sort of a larger proliferation of papers that have tried to use that approach, that sort of some change happening in order to understand what the effects are of dealing with upstream social determinants more than downstream programs. And the examples I'm going to show you come from Canada. And actually, I'll tell you, we are recently in the process of, we're under review for a paper where we looked at the effects of social policies on child health. We essentially did a review of the literature. And something really interesting came out, which is that all of the Canadian examples were examples of income supplements, income transfers, if you will, unconditional cash transfers. And so here are a couple of examples from Canadian unconditional tax transfer programs. This is the work of Brownell and colleagues out of Manitoba, where they looked at the effects of an unconditional tax transfer for moms. And they found that the unconditional tax transfer that was fairly low, it sort of fluctuated a bit by circumstance and family size and so on, but it was in the neighborhood of $81 a month. This had a positive effect on breastfeeding initiation. It decreased the proportion of babies born low birth weight by over 20%, and the babies born preterm by almost 20%. So a really striking effect of a rather modest but unconditional cash transfer. This is another study out of McGill where they looked at the effects of the universal child care benefit on food insecurity and found again that compared to controls that were eligible but did not receive the cash transfer, that the people who did receive the cash transfer really had a massive decline in food insecurity. And their results suggested that overall there was a decline in about 2.4% in food insecurity attributable to this unconditional cash transfer. And in low-income populations, that went to 4.3%, a 4.3% reduction in food insecurity. So these unconditional tax transfers seem to have a substantially beneficial effect on a variety of health outcomes and risk factors for health. In the United States in the mid-90s and in Canada, there was, as you probably well know, real effort to kind of rejig welfare, essentially reform it. And by reform it, I mean cut it back, increase the stipulations that made it accessible, decrease the longevity that you could, over time, during which you could receive benefits. In the US, it was actually even more stringent. And recently, we just published a paper where we did the same thing, that quasi-experimental design, to look at, in the US, at what happened before to welfare recipients before those reforms and after them. And I'm kind of trying to replicate this in Canada as we speak. So here are the results from our US study. And the blue dots are the dots for single moms who were employed during this period. And the orange ones are single moms who were not employed. And essentially what these results tell you is that in all cases, and even more so as you would expect for unemployed moms, welfare reform resulted in a decline in health status across a variety of health outcomes. Everything from drinking and smoking through to having a pap smear or a mammogram. So there was this broad spectrum effect of this change in your fundamental resource access. And as Lincoln Phelan from Social Conditions as Fundamental Causes tell us, as our social determinants tell us, it's because these social determinants affect so many mechanisms leading to so many outcomes that you see this kind of broad spectrum effect. So if you think about another way to study this issue, so one way is to look at whether policies have changed over time and then assess that temporal change. The other way is to compare societies that have different policies, and this is actually where much of the policy literature started, and where I started much of my work is to do comparisons between Canada and the US. And the idea is that these are two societies that are very similar in many respects. They're both quite wealthy, they're both ethnically diverse, they both are arguably democratic, and so on. The question is, when two countries are fairly similar but are still different in their policy approaches, can we learn something about how different their health outcomes turn out to be? And this is a graph that shows differences between the US and Canada in life expectancy. And in both the case of females and males, Canada has had a significant lead on life expectancy from about 1980 onwards. And that gap really has not closed. And it's a significant gap. It's about 50% difference in mortality in some adult age groups. And the question is, why is this the case? Both have economic resources in general terms, are quite wealthy societies, again, fairly high functioning in many regards. Why would there be this significant health difference? Well, it's not even just the overall life expectancy that's different, but as we've been learning, also accompanying that are differences in health inequalities. This is something we did last year, where we looked at differences in obesity inequalities in Canada and the US, and you can see there on the left that the US has both higher levels of obesity as well as a steeper difference in obesity prevalence across income quintiles, where Canada has overall sort of lower levels and a much less steep gradient in obesity. We recently looked at racial inequalities in health, which is something that hasn't been examined too much in Canada, but is very common in the States. And this is a picture of what we found for black-white health inequalities. And the bars going sort of below the one line there mean a protective effect for blacks compared to whites. And US is in blue and Canada is in red. And the top sort of set is the actual raw statistics before you control or adjust for anything. And you can see that there are real differences in the extent of protection as well as the extent to which blacks compared to whites are compromised in their health in Canada compared to the US. So you can see, for example, for heart disease, in Canada, blacks have a much more protective effect than blacks in the US. Conversely, in the case of hypertension, blacks in Canada are at higher risk than whites in Canada, but the gap is smaller than the gap for the US. And when you control for a bunch of covariates, age, sex, immigrant status, etc., health insurance in the US, you see that some of the protective effect of sort of the narrowed gap in Canada reduces. In other words, the gap between blacks and whites increases, and that's partly because these factors are what is protecting minorities in Canada compared to the US. So the reason for the larger black-white gap in the US in terms of social determinants is the reason that blacks are more protected in Canada. So again, overall, better health status in Canada and lower levels of inequalities to a large extent in Canada. We're not perfect, but comparatively speaking, we seem to be in better shape. So the question is, why? What's different about Canada and the US? And the healthcare system is an issue, but as many of you know, It's not usually what causes incidence of disease. We need the healthcare system tremendously, but it doesn't tend to account for a bunch of the effect sizes. So in many of these cases, we've controlled for health insurance, and it did very little to change, in control for health insurance in the US, and it did very little to change our estimates. So we think the answer is probably more related to the policies that govern social determinants rather than govern the health system. And this is a table that shows differences in income inequality in the two countries, and income inequality being one factor we think might be operating. And if you look over time at pre-tax transfer Gini, so this is before the government does anything with our, before we pay taxes, before we dole out transfers. And you can see actually the US and Canada are not that different. So based on our market incomes, on what we earn, we actually have fairly similar levels of inequality. What's different is how we tax and transfer. So the way that we use policies and programs to redistribute income changes drastically the level of income inequality that we end up with. And so if you look here, in the after taxes and transfers, you start to see larger gaps, much larger gaps opening up between the US and Canada. So based on market income, the societies look fairly similar. After redistribution, that's where the action is. And again, that's a social policy story. That's a story about how two countries use policies differently to tax and transfer across groups. So if you think sort of collectively about the other kinds of social policy differences that happen across Canada and the US, there's kind of a variety of ways to think about social policy differences. One is the fact that in Canada, what we've seen is that overall we have higher levels of social spending. So we're spending more on our social programs than is the United States. So again, our social determinants are somewhat more buffered and taken care of in comparison to the United States because our government invests more in these kinds of factors. If you look at even times where the US is growing economically far stronger than we were in the 80s, we had higher unemployment than they did, lower growth, but we were still spending more on social programs than the US. The other sort of issue, I think, is that we have greater universality, and I would add unconditionality of many of our programs. So the fact that we have a greater extent of social goods that are available for consumption by everybody, that are sort of equally distributed and equally used. Healthcare is amongst them, but you can think of many others. Education. The way that these kinds of programs are funded at some core level tends to give them a more universal quality. In the US, those kinds of programs are very much dictated by your individual income and that of your neighborhood. And again, that idea that what we are effectively doing through policy is a greater extent of redistribution of spending. I think education is actually a really good example in this regard. Our other keynote speaker will probably be able to attest to this. But in the US, public education is not just public education. I'm sensing now that I'm back in Canada, this is somewhat more contentious than when I was growing up. But in the US, your local public schools quality is very much dictated by your local property tax base, because they simply do not redistribute funding for education across neighborhoods the way we do. So the reason our schools are more likely to be similar is not necessarily just because we all are living in mixed income neighborhoods. We're not. But what we're doing, despite the fact that the incomes of our neighborhoods are so different, is we're funneling property tax up to the province and redistributing essentially on a per pupil type basis. And so you get much more equal school funding than in a situation where rich neighborhoods get to keep their property tax money for their schools and poorer ones are left to their own devices. So this sense of redistributing spending is also a major factor. I also think there's something to be said about what sociologists often call the social imaginary, or some sort of variant of that. If you look at the discourse in the United States when welfare reform was happening, you could sense that there was a real racial overtone, not even an undertone, to the discourse. It was that the government was essentially selling welfare reform as a way to combat minorities abusing this free money they were getting. It was totally preposterous, totally unsubstantiated by any data. But they very successfully sort of tapped into a narrative that is very alive and well, very palpable. And I think we have some of that, but I think we do a better job of creating some kind of social cohesion that, or at least some kind of way to check people from forwarding those kinds of narratives and perpetuating them in the media. So in our case, welfare reform, as egregious as it was not carried out overtly as an ethnic project. And I think that's not insignificant. I think this sort of class-race tension in the US has a lot to do with the extent to which they are able to redistribute, and is a major difference in why we've had less trouble doing so. Again, this is not an argument about Canada being not even just perfect, but being okay. But if you compare the societies, the kinds of factors that help some societies do better and are the direction we should probably be going in compared to societies that are really having some trouble, bring up these kinds of cohesion factors as well. So what can societies do to address the social determinants of health, sort of the question that I started out with? My sense is they can address the social determinants of health by addressing the social determinants of health, by addressing the actual social determinants themselves, rather than addressing those determinants by going for these more proximal mechanisms. It just doesn't seem to work. And so the question is, can we start to move away from this part of the framework to this part of the framework? I think what the evidence, both from research as well as the real world, is showing is that time and time again, we try for this and it doesn't quite work out. I think the Vancouver example tells us that community organizations and people who are invested very well-meaningly cannot do it on their own. There's no way that you can sort of substitute the effect of major economic forces by doing something just at the local level without engagement from higher levels. Public health agencies can't do it alone. Toronto Public Health did not succeed, not because they didn't do the right thing, but because it's not for Toronto Public Health to do alone. The kinds of engagement with social determinants that is needed goes far beyond the capacity of Toronto Public Health, goes far beyond the capacity of any of these individual organizations. This is a graphic that we produced in the context of child development to kind of highlight how intertwined different levels of society are in producing health for children, but I think it very much applies across the life course. And the idea is that we're all embedded in this nest of environments, from the family all the way through the global environment. And in fact, some environments that aren't geographically bound, things like relational communities and ECD services and programs, and by extension, healthcare services and programs. And it really does take the network of people who are passionate and engaged and unfolding programs at the local level, and people and institutions and organizations and governments that can resource those people and resource those programs in order to create some change, as well as the sort of glaring kind of issue, which is that if we don't have engagement from the institutions that govern the redistribution of resources, it's very difficult to overcome such systematic health inequalities. And I'll leave it at that. Thanks.
questions, if anyone has any for Dr. Siddiqui.
So I'll be the first one. I haven't looked in depth into that EDI, so forgive me, but it talked about development. So, but I didn't think learning disabilities and developmental disorders change over time.
Yeah,
So I'm wondering what development it's talking about.
really
And
good question.
that affects your conclusion over like economy, because like I suppose economy, I mean we have mind-body connection, so and obviously environment and therefore economy can affect that, but I just wanted a little bit more clarification.
That's a very good question. You're quite right. So this was not a tool that was developed to be sensitive to particular diagnosable developmental issues like learning disabilities. It's really a tool that's meant to measure at the population level what is the range of reading comprehension, what is the range of social developmental skills, what is the range of physical development in children. And vulnerability is essentially defined as being sort of at the lower end of your population. So it's not a fixed notion of vulnerability. It's really a notion of the fact that if you take that there is a spectrum in the population of how well children are developing in general, and there are certain children that fall on the lower end of that spectrum, is that socially patterned? And the answer is yes.
Thanks.
And starting now, if this person with the question could briefly introduce themselves, please.
Starting with my colleagues.
Richard Muskell, I'm the medical officer at Doctor in Calgary. The comparisons that you've done between Canada and the United States are striking, but I wonder, given in Alberta we feel a lot like we're the America of, in a sense, of Canada. Have you done those comparisons between provinces that would help us if you did?
Well, I appreciate that. So I haven't yet done the comparisons within provinces, and I'll offer both an apology and an excuse, but I think the excuse is quite valid and important to share. So I did much of this work while I was in the US, and for example, one survey that I used was called the Joint Canada-US Survey of Health. And I was able to download that survey from the US Center for Health Statistics, the National Center for Health Statistics, that was a partner in that study. And I downloaded it, we did our data analysis, and away we went. Well, in Canada, it's not so easy. And actually, I should say the one caveat is when I did download it, I wasn't able to access the race data in Canada. I could access it in the US, for the US sample, but I couldn't access it for Canada. And when I got to Canada, I learned how difficult it is to access what I would consider to be public data. And the sample sizes are often prohibitive for doing comparisons like you're suggesting in any empirically sort of meaningful way. So for example, our race estimates are, to me, very preliminary because racial groups are very underrepresented in the CCHS, even when you collapse all available survey years. So the short answer is we should. The longer answer is I can't even promise that we can, because the constraints on the sample sizes as well as accessing the data are often pretty stringent. It's something that's I think Canada's going to have to contend with. It's really tough to keep up. Even the welfare reform study, I mean, we're sort of bending over backwards to figure out how we can use Canadian data to study the same question in the US that we could study for days and months and weeks and years there.
Bill Galley, the scientific director of the Institute, thank you for your talk. Just picking up on the question about Richard's question about comparisons within Canada, and also picking up on your notion that the Vancouver, the negative change in Vancouver may have been the economic downturn, and of course we have one now. There's a fascinating contrast in the natural experiment really in two Canadian provinces. The provincial budget brought forward in in Newfoundland relative to the provincial budget here in Alberta, where the two provinces are really facing a similar economic challenge around price of oil. Newfoundland's decided to go the course of significant increases in taxation, whereas the Alberta, and really I think maintaining spending on social programs, Alberta, similarly, our NDP government has brought sustained spending in a number of social areas, and we have David Swan here, so he could correct me if I'm wrong, but sustained spending, but running a deeper deficit. So
Wow.
do you have a comment about those two approaches? What could the effects be? What will happen to our geographic map of social determinants of health and decline?
I mean, I can't, there's hardly anything for me to say because you said it so beautifully. That is a terrific idea for a natural experiment, and if there is data that you think would be available, I'm sure that is very doable. I'm happy to talk to anyone who'd like to engage in that, even just as an advisory capacity. I think that'd be a great idea. So the one methodological issue, let me bring up a couple. So the ones that we face often are that populations tend to be very different from the outset. So you can kind of statistically maneuver that, but one counter argument will always be that these are two different places anyways. So that's one issue. The second issue may be that it depends if we can isolate the change in the budget changes from other changes happening contemporaneously. And again, there's often statistical ways to correct for those things, but that's the challenge of natural experiments, is how do you compare groups that are similar in every way possible, except that they underwent different policy reforms. And so as you're thinking about other experiments that one might be able to test out, that's kind of the question, is can you isolate what you want to isolate sufficiently?
Do you have a sense of which of the two approaches is better?
I think for what you're suggesting, there is, so there's something that we routinely use, which was used in many of the studies I pointed out, which is called difference in differences. That is kind of the standard way to net out the fact that Alberta and Newfoundland are different in many other respects. And there's a newer method called synthetic control. And in synthetic control, you essentially don't rely on the investigator saying, well, I'm going to pick this society, Alberta, that went through one type of policy change, and my comparison group is going to be Newfoundland that went through another. You actually pick a range of alternatives. So you could, for example, compare Alberta, Newfoundland, and maybe the rest of Canada, and say, look, this is how similar or different their trajectories are, so you could at least get a relative sense of what happens when you have a different in budget approaches.
So I actually am going to take Chair's prerogative and ask a
Yes,
question, if
sure.
that's okay. It kind of goes in the opposite direction of Richard and Bill's comment. So I agree that the differences between Canada and the US are very striking. But there's another...
Sorry.
In other areas of research, such as the literature on welfare capitalism, Canada and the US are actually grouped together as
Yes.
liberal welfare regimes and contrasted with other even more different forms of economic organizations, such as more social democratic leaning societies. So I'm just wondering if you can comment on these, I guess, within versus between
Yes,
regime
yes.
differences and how we navigate that.
It's a great point. So you're quite right that if you look at the political economy literature, Canada and the US are considered liberal welfare regimes, along with the UK and Australia, contrasted with places like Sweden and so on, that are much more social democratic than we are and have much more redistribution. And the findings have been that those societies tend to do better in many ways, though we're learning that's not always the case. So for example, their absolute health levels are a lot better, but in some cases their inequalities are larger. So one problem has been, again, I will say this is another Canada data issue. If you look at the cross-national work, Canada is virtually absent. So the US is really the exemplar of those liberal nations, partly I think because the US data is much easier to get. But the other issue in comparing these countries is this issue of how similar or different they are across many other axes. So Sweden, one argument that's made about the Sweden trajectory is that it's relatively racially homogenous. They haven't had open immigration until fairly recently, and lo and behold, when they started having non-white immigration, things are kind of changing in social policy terms. And Will Kimlicka, a great political philosopher at Queen's who does work on models of multiculturalism, points out that actually Canada is a nice example of a place that is both ethnically diverse but has maintained some modicum of redistribution in its policy agenda. So it's a nice contrast between you have to be lily white for redistribution to occur, and you can't have it at all because of ethnic diversity. So there's that. The other kind of thing that I always think about is, and I don't think I factored this into my own analysis sufficiently, is the extent to which history matters, whether trajectories matter or not. And I don't know the answer to that. I have a great doctoral student who would probably do a better job of answering this question than me. But it's like the difference between saying that the history of plantation-based slavery in the U.S. is a statistical annoyance that I have to net out in order to compare Canada and the U.S. versus this is actually why we have differences in policies, right? So the same is true for the extended social democratic nations. They have had very different trajectories that they've operated with. I will say the other sort of contrast, though, is what happened during the decline of communism in Central and Eastern Europe. And if you look at the way Finland, which was not communist but very influenced by what was happening because Russia was its major trading partner, the way Finland played out is very similar to what you're describing in Newfoundland, in the sense that their economy really was suffering, but instead of buckling down and reducing resources and shrinking its welfare state, they said, we're going to spend our way out of this. So they improved social spending, they improved unemployment protection, they actually acted as a private equity company for companies like Nokia phones, which is now, seems like a million years ago, but for companies to be able to hire people with the agreement that they were going to pay fair wages, that there was going to be all kinds of checks and balances so that money did not get filtered right to the top of the company, but actually was distributed throughout. So there is ways, even in the presence of trajectories and histories and major macro moments, that policy decisions can actually make or break what happens to health inequalities.
Hi, Marie, thank you so much.
you.
I'm with Alberta Health Services. I'm going to bring it down a level or two. Thank you for this thinking. I know it's been in academic circles and among researchers for some time. It hasn't really permeated into public health and health promotion practice as far as you're talking about it. And in any case, most people say, well, that's not our job anyhow. I appreciate that. There is still a very strong penetration of risk factor emphasis in a lot of public health work. And this might sound self-evident, or I don't know, but is it a matter of intentionally looking at the impacts of social determinants of health on these different mechanisms or diseases in different populations and just making it much more evident? Because we seem to be missing that, I think. And this is also a big issue. You have said, and we know, when Toronto Public Health can't do it also, how can one organization do it all? So what do we do? I know that's a big question, but how can we move in that direction a little more intentionally?
So I wish I knew. I will tell you what I learned from the WHO Commission work. The two things that stick out to me, one is that it's often the case that you just have to seize opportunities when they arise. So you can't always plan this out neatly, that sometimes it's accidents of people who happen to be engaged in issues that you meet and can latch on to. Policy scholars call these sort of policy windows. And I think it's not trivial, and here's my example of that. I had nothing really to do with this, but Clyde Hertzman and I and a few others from UBC were at a meeting of this WHO Commission in Geneva. And, you know, we produced a very nice, lovely report. It's glossy and it's you know, we put a lot of time into it. I cannot guarantee you, or even, I don't even think it's probable that it did much. Concretely, maybe. But I'll tell you it did do something. Clyde met someone at lunchtime in the cafeteria. And he was a lawyer who worked for the Convention on the Rights of the Child. And they struck up a conversation. And now, some years later, child development is part of what countries report on for Convention of the Rights of the Child. He just grabbed whatever happened to come along for him. And I think that actually had much more of an effect than our glossy report did. So I think it's not trivial to sort of capitalize on these moments. The second thing I would say is that from what we learned, even more than advocating for specific policies, we have to somehow figure out ways to create mechanisms that allow us to routinely think about policy making from the lens of health and health inequalities. So a lot of what those social democratic welfare regimes do is not only to implement policies that are beneficial, but they have actual bodies, institutions, boards of one sort or another that are charged with analyzing how different policies made by different government ministries will affect, for example, children. So Gosta Esping Anderson, who's one of the sort of godfathers of these regime type approaches, has a book called something about needing a child-centered social development strategy. And I think where he's going with that is that, you know, it actually matters that every time policies are made by ministries in the Scandinavian countries, those ministries are responsible to this board who thinks about policies from a child's perspective, from the welfare of children's perspective. They're responsible for saying, how is this going to affect children? And they have to actually be accountable not only for labor policies affecting labor, but how labor policies affect children and families. So in some senses, I think the policies are an important discourse, but so are discourses about mechanisms that actually kind of integrate that thinking into how we make policies in general.
I think we have time for one more question. Deb.
Thanks, Deb McNeil from Alberta Health Services. I was fascinated with your slide looking at the physiologic aspects and allostatic load. There's been a lot of research now around intergenerational trauma and longer-term impact. Have you looked at all of that in any of your work, and what are your thoughts about that?
Yeah, so I haven't looked at it, and I know a tiny bit about the intergenerational perspective at least. And I have sort of two thoughts about it. I think there are some really strong, legitimate issues around the intergenerational impact of trauma. Sort of, that literature seems to have gone in a psychological direction, and rightfully so. There are a lot of the intergenerational effects are psychological, but I'm a little of two minds about focusing on the psychological aspects, because I'm not totally convinced that, again, a social determinants lens on that wouldn't help. And I say that because if you look in the US at, for instance, wealth inequalities, the major source of black-white wealth inequalities in the US is not income differences in present day employment. It's certainly not education differences. The main story of black-white wealth differences is intergenerational transfers. It's the fact that over generations, whites have been able to accumulate enough wealth to give gifts to their sons and daughters, to give down payments and to pay for education and to give you a sort of leg up in life. Those are things that we often trivialize, but are really what make or break an economic trajectory. And so I'm not totally convinced that we couldn't buy our way out of this intergenerational trauma. And if we were to focus instead on what has happened, not just in terms of trauma, but on the social and economic conditions that need to be rectified, in that intergenerational lens, I think we would get, you know, again, a sort of larger perspective on what one might do to resolve this. So I'm all in favor of the intergenerational lens. I do think that is not sufficiently addressed in social determinants work, including my own, and it's very significant. But I think a large part of why it's significant is because it highlights how long social and economic inequalities have been perpetuated and what their sort of cumulative effect is.
So please join me in thanking Dr. Siddiqui.
Thank you.